Hi, good morning. We're going to get started here. It's my distinct pleasure to introduce our guest speaker today, Dr. Gina Lundberg. Dr. Lundberg is the developer and the clinical director of the Women's Heart Center at Emory in Atlanta. She's also a very active member of the ACC and, for those of you who are in the social media, the Twitterverse. I think this is our first time in the land of 10,000 lakes, so let's give her a big and warm Minnesota welcome.
Thank you so much for having me. It's a real honor to be here. What Dr. J said is true. This is my first visit to Minnesota, and it was so nice to be in a state where people actually understand that you have a Scandinavian name and know how to say it, because in Georgia nobody gets it right. So I feel like I'm among my people today. So I'm really going to talk to you about heart disease in women and preventing heart disease and stroke. I have no disclosures. We're going to go through the guidelines quickly. We're going to talk about the stroke prevention guidelines, which a lot of people don't even know exist. And then we're going to discuss unique risk factors in women. So preventing heart disease in women. So we're going to do a little audience response, even though you don't have one. You don't have to raise your hands. Just think to yourself, what is the answer? So what is true? A, more women die of cardiovascular disease every year compared to men. B, women have more burden of AFib compared to men. C, diabetes and hypertension are the same risk for women and men. And D, sex differences and gender differences are really the same thing. So got it in your head? All right. So the answer was B. It is not A. We can no longer say that more women die of cardiovascular disease every year than men, which is something we enjoyed saying for a long time. So from this graph, you can see all of these years, more women were dying of heart disease than men. But here in 2012, the lines crossed. And as a preventive cardiologist, what I find very worrisome is that both lines for men and women are going back up. So we were doing something well, but we're not doing it well anymore. So what is it? So probably the big thing with women and heart disease is we started a campaign to increase awareness for women with heart disease, the Go Red for Women. That started in 2004. And that's also about the time that we realized that hormones were not preventing cardiovascular disease. They might have actually been contributing to cardiovascular disease. So that's when the Women's Health Initiative kicked in. So there's several things that happened around that time. So there are differences in women and men when it comes to ischemic heart disease. And this infographic very nicely shows that we have traditional risk factors, but we have these new emerging risk factors. A lot of people don't understand that rheumatologic disorders like rheumatoid arthritis and lupus increase a woman's risk of ischemic heart disease threefold. And this is a large audience that Women's Heart Centers are now working with. Gestational diabetes is a 4 times higher risk of diabetes, but a 59% risk higher for myocardial infarction. So we're trying to get these women right after these complicated pregnancies. Hypertension in pregnancy, and especially preeclampsia and eclampsia, increase the risk of ischemic heart disease at least threefold, and that risk kicks in fairly soon. Early menopause is a 4.5 times the risk for ischemic heart disease, and depression, stress, even domestic violence, these all contribute to ischemic heart disease in women. And the traditional risk factors are not created equally. So what do we see when it comes to disparities in healthcare for women? We see less diagnostic tests, particularly angiography. When I started my first Women's Heart Center in 1998, I was seeing a lot of women who were being told it's stress, it's gastrointestinal, never had an EKG, let alone an exercise stress test or a nuclear stress test. Delays in reperfusion. We're not getting them to the cath lab as quickly as we get men. Fewer revascularizations, not only with coronary artery bypass surgery, but with stents. Less pharmacotherapy. Women are not being sent home on beta blockers, statins, just traditional cardiovascular risk-reducing drugs. Less cardiac rehab. In the early 90s, it was noted that about 3% of women were going to cardiac rehab. 3%. So we don't tell women they should go. We assume they don't want to exercise, that we assume they won't benefit from it. But women need to go to cardiac rehab too. They have better outcomes, fewer hospitalizations. Higher morbidity after a myocardial infarction, and this is in part due to more comorbidities prior to the myocardial infarction. Higher in-hospital mortality rates with angina, STEMI, and acute coronary syndrome. And our younger women are more likely to die from cardiovascular disease due to the delay in identification as well as lack of treatment. Diabetes is not created equally in men and women. It's about a 4-fold increased risk for women, 2 to 3 for men. Tobacco increased in our young women. About 25% or more of our college-age women are smoking. It's cool again to use e-cigarettes and vape, and so more of our women are using nicotine products. And it's very important to get them to get off cigarettes. Multiple drugs out there to use for it, Zyban, Chantix, these can be very helpful. Hypertension is more common in the older women, and unfortunately obesity is much more common in women. So in my state, in Georgia, 70% of women are obese or overweight. So we have a huge problem in the South. It has a lot to do with the Southern diet, and people are just very inactive, very sedentary. When you think with all that nice weather, we'd be out doing stuff. But I was talking to Dr. Jay that we're much more sedentary in Atlanta, and the physical inactivity I just covered. So women have a higher prevalence of angina, but a lower burden of obstructive coronary disease. So for years, a woman would have angina, we'd take her to the cath lab. She might have what we call luminal irregularities, mild blockages. Maybe you even noted a 40–50% on the cath report. But she was told it's all good, and what we meant was you didn't need a stent, you didn't need an intervention. But she had atherosclerotic plaque in her coronary arteries. Women have a poorer prognosis compared to men, and the clinical presentation, while it can be different, is also the same in women. So about 60, 70, 80% of women will present with traditional chest pain in the sternal area radiating to the left arm, the jaw. But because a lot of women, maybe 40%, presented with these more atypical symptoms, it sort of got the idea that women always present with an atypical presentation, but it's not true. I'd say the difference that you need to look for is it can be more subtle. A lot of times a woman doesn't want to use the word pain, right? Because you women in the audience know we're pretty tough. We take a lot of pain. Childbirth is not easy, right? So when we use the word pain, we mean it to be something really intense. Chest discomfort is a better word because it might feel a little heavy, a little tight, but they also might have that tightness or heaviness in their jaw, their abdomen, their back. I tell women basically from your belly button to your earlobes, left, right, front, back, it could all be angina. The other thing that's real subtle in women is they tend to complain more of just fatigue, shortness of breath. I used to could walk up the stairs carrying the laundry basket, and now when I get to the top, I have to stop. I'm tired. And most people will write that off to, I'm just getting older. So look for subtle symptoms in women. Another big problem is awareness, and it's among physicians and primary care. So only 45% of women still know that cardiovascular disease is the #1 cause of death in women. At Emory, I work with our medical students, our NP students, and our PA students. And just last week, I was working with a PA student who wants to work in OBGYN. So I said, well, do you know what the #1 killer of women is? And she thought a minute. Now, this is a woman with a master's degree. She's very smart. This is not about her. But she said, breast cancer? And unfortunately, that is still perceived to be the big thing women need to worry about. Breast cancer, ovarian cancer, what we call bikini medicine. But overwhelmingly, heart disease is the #1 killer of women. Was, and it's projected that it still will be up until 2050. Only 26% of women find cardiovascular disease something that they're ashamed of. They think it's related to things we do in our lifestyle. They totally neglect the genetic component. So they think, well, I'm overweight and I'm sedentary and I eat too much fast food. It's my fault. I don't want to talk about it. It's embarrassing. So we also have to find a way to disconnect shaming people about their lifestyle and their health habits. I've got really skinny women with horrible cholesterol and blood pressure, and I've got very large women BMIs at 35, 40, and they have good cholesterol and good blood pressure. So you can't judge a book by its cover, and we don't want to let our women patients feel judged by cardiovascular risk factors. Only 40% of routine care even includes a cardiovascular risk, and that's because most women up until the age of 60 are still seeing an OBGYN. Some are seeing family practice and internal medicine, but most are still going to a women's health physician. Only 39% of primary care physicians feel that cardiovascular disease is a top priority. And I'm sympathetic to that. When you go to your primary care doctor, they're too busy checking these. Did you get your flu shot? Did you get your mammogram? Did you get your colonoscopy? By the time they've gone through that checklist on the EMR of things they have to account for, there's no time to talk about heart disease. There's no time to talk about your systems or even doing an exam. So part of it is the time constraints in healthcare. But only 22% of primary care physicians and only 42% of cardiologists feel well prepared to assess a woman for cardiovascular disease. That's an educational problem. That starts in our curriculum. And women and heart disease is a section on the board for all cardiologists. So we have to get more comfortable with studying this, understanding this, and definitely look toward researching this. So what do we recommend for women? Well, all the stuff we recommend for men: hypertension control, diabetes control, lipid control, lifestyle improvement, smoking cessation, and getting body mass index down to a more reasonable, healthy number. So when you see a woman in the clinic, you need to start with the history, but make sure you're including what happened during your pregnancy. And this can be really interesting when the woman's 65 years old and she's wondering, why is this cardiologist asking me about my pregnancy? That was a long time ago. But any high blood pressure, even at the very end, even at labor and delivery, counts as the risk factor. And gestational diabetes, the guidelines for these older women were very liberal. So if they had a baby over 9 pounds, they probably had gestational diabetes that was unrecognized. You want to ask about the rheumatologic disorders. Lupus, rheumatoid arthritis definitely increase the risk, but we're also learning that psoriatic arthritis is probably going to be on the list in the next guidelines. And there's increasing data about Crohn's disease. So these chronic inflammatory illnesses increase a woman's risk of cardiovascular disease. We know a lot about breast cancer and the treatments causing cardiovascular disease. There was a major statement from the ACC and the AHA in the spring about this. Very important these women need to be followed for surveillance long term. They can be developing cardiomyopathies from adriamycin toxicity up to 20 years after the treatment. So you really need to keep watching these women long term. If they had radiation, particularly over the left breast, that also increases their risk. And then women who are suffering with depression, stress, traumatic problems, domestic violence, these are all adding to their cardiovascular risk factors and should be noted as a cardiovascular risk. We definitely recommend the ASCVD risk calculator for defining risk, but it tends to underestimate young women and overestimate older women. So it's just a guideline. It's not hard and fast. And then we have controversies in how to treat women. The U.S. Preventive Service Task Force just came out about a month ago with the new guidelines for aspirin. And as usual in Atlanta, everybody turns to CNN headline news. And of course the line was, aspirin doesn't help. No explanation, no indication of which group, aspirin doesn't help. We had a million phone calls. What do we do? What do we do? So the guideline is between 50 and 59. If the cardiovascular risk is over 10%, which is what it used to be, it's a Class B recommendation. It's probably good. It's not hard evidence. And for adults 60 to 69, it's a little less. So you want to take into consideration that there's going to be a GI bleed or is there going to be a problem with it. And for adults under 50 and over 70, there's just insufficient evidence. We don't know that it doesn't help. We just don't know that it does. But for secondary prevention, we're still using it in all categories. And I don't think the news did a good enough job of explaining this as primary prevention for very healthy individuals over 70. The statin recommendation is unchanged, but as you guys may know, in 2 weeks, AHA is going to be in Chicago when we're going to get the new cholesterol guidelines. So I'm not really going to spend any time on this, but basically if the ASCVD risk score is over 7.5% for the 10-year risk, or they already have known coronary artery disease, they should be on the statin. And women do benefit from statins. There's been a lot of controversy over that. So here's a chart of what women have been getting traditionally when they leave the hospital. And let's see where I'm, oh, gosh. Here we go. For reperfusion treatment, beta blockers at discharge, ACE or ARB, aspirin, statins, antiplatelet, dual antiplatelet therapy, always favoring men. Women aren't getting the treatment. The one thing we do feel comfortable giving women is nitrates. That's pretty 1970s treatment, right? So we've got to do a better job of sending our women out on evidence-based, guidelines-driven medications. So there are some things that are more common in women. They're kind of sexy to talk about, so they're always fun. Women have more plaque rupture. Women have more coronary vasospasm. Women have more spontaneous coronary artery dissection and stress-related cardiomyopathy, or what we call Takotsubo. So plaque rupture is what we have to think of as traditional atherosclerotic problems. This is more common in older women. They have the traditional plaque rupture, which causes acute coronary syndrome, or MI. It is definitely associated with hyperlipidemia and a weak plaque with a thin fibrous cap. But in younger women, we're seeing a completely different animal. It's plaque erosion. And this is associated more with smoking. Again, very important to get these young women to quit smoking. Estrogen may be protective in this, but we don't think exogenous estrogen is going to help. The plaque is a different type of plaque morphology. It has more smooth muscle and proteoglycans, and it's less obstructive and tends to be more calcified. So this will show up on a coronary artery calcium CT scan. So spontaneous coronary artery dissection, or what I will say SCAD for the next few minutes, it's also different in women. There's pregnancy-related SCAD, but there's non-pregnancy-related SCAD, and that obviously can also happen in males. In women, pregnancy-related SCAD is more common with eclampsia and preeclampsia, seen in peripartum cardiomyopathy, and there's a strong connection with fibromuscular dysplasia. So these women need to be evaluated with their carotids, their renal arteries, really a full-body angiogram or MRA to look for that. So this was a study that was released that showed the difference in pregnancy SCAD and non-pregnancy SCAD. So P-SCAD is pregnancy, 54 women, non-pregnancy, 269. And as you can see, there's more STEMI with the pregnancy SCAD. Also, they tend to have lower ejection fraction. 26% had an EF below 35%. About a 42% association with FMD, but much stronger in the non-pregnancy SCAD, so this will be in the men and the women. Very common in multiparous women and also women who've had infertility treatment for the pregnancy SCAD, and about twice the number having preeclampsia with pregnancy SCAD. Way more pregnancy SCAD is going to be left main, so about a 25% chance it's going to include the left main, and the multivessel. Sometimes it's going down the CIRC and the LAD. And these women tend to be younger because they're childbearing age, and in both groups they're overwhelmingly Caucasian. So it's not all the same, and this is why it's so important to do sex-specific research, because we're learning that they are different and they need different treatments and they're going to have different prognosis. So MINOCA, MI with non-obstructive coronary artery disease, it's about 6% of all MIs. SCAD's about 4% of all MIs. So that's 10% of your MIs. So I know we have the cath lab director and other interventional cardiologists here. This is happening probably at least once or twice a month in this institution. I hope you guys are great at picking that up. It's very important. And then if you can get them in a registry, that's also very important. At Emory, we have a Scad registry. The median age is 55. So these are your younger people with fewer risk factors. 40% are women. It can be vasospasm-induced or thrombotic disorders, so we always look for things like Lp(a), factor V Leiden, protein C, protein F. And it has a very guarded prognosis. They have a higher major adverse coronary events with this. And then there's Takotsubo, which we all love to talk about because we think it's so rare, but again, it's not. Multi-vessel distribution of LV dysfunction, but basically normal coronary. It's usually after an emotional trigger. I always love that one of them is public speaking, so when I get done, I'm always like, okay, am I okay? And it can be acute coronary syndrome with no obstructive, multiple artery territories affected. And there is Microvascular endothelial dysfunction, we talk a lot about this, particularly with women. Very difficult to diagnose. In Atlanta, we use PET scanning with this to look at coronary flow reserve and to see if that's the problem. The PET's really nice too because it gives you a CTA, so you get anatomy, you get perfusion, and you can look for microvascular dysfunction. PET machines are also very, very expensive, and a lot of centers don't have one. Do you all have one? Good for y'all. So that's like the perfect women and heart disease test. It does have a higher outcome of comorbidities, so you're still going to see acute coronary syndrome, you're still going to see troponin elevations, you're still going to see chronic angina and disability with this. So don't tell them they're okay, they're not okay. So let's shift to stroke a little bit because most cardiologists are very comfortable with everything I talked about, but we're not comfortable with stroke. In fact, we sort of think that's not even our part of the cardiovascular system, but it is. Just like we're becoming endocrinologists, we're becoming neurologists too. Okay, so which is true? A, women with migraine have aura. Women who have migraine with aura have a higher risk of stroke. Men with AFib have a higher risk of stroke compared to men. I just said that wrong. Men with AFib have a higher risk of stroke compared to women. The hypertension risk is the same for stroke in black women compared to white women. And gestational hypertension does not increase lifetime risk, which is true. And the answer is A. So the scope of the problem is really high. All right, women have more disability and more long-term problems after stroke than men. And why is that? Well, first of all, they're more likely to have problems before the stroke. They're more often widowed, living alone. And then after the stroke, they are more often institutionalized. There's no one to take care of them, no one to help with rehab, and they have very poor recovery. And nearly half of the stroke survivors still have significant disability, even 6 months after a stroke. So this is a real health care cost burden to our country, and we need to do a better job of preventing stroke because once it's done, it doesn't get better. It's the fifth leading cause of death in women and fifth leading cause of death in men and the third leading cause of death in women, so it affects both populations. Over 4 million strokes in 2014, and the stroke deaths was over 77,000. So this is significant. And if you add stroke and heart attack together, it's overwhelmingly the #1 cause of death, more than all cancers combined. So the prevalence of stroke is more common in young women. So if you'll see here in the 20 to 39 group, more women. In the 40 to 59 group, more women. And in the 80 plus, more women. So while the 60 to 79 age range, we're going to see more strokes in men, overwhelmingly more strokes in women in the younger and older age groups. So in 2014, the stroke prevention guidelines for women came out. Did anybody know that? So in 2004, we had the first guidelines for prevention of heart disease in women. It was a big deal. We had Go Red dresses, yay. And the stroke guidelines came out and it was kind of like crickets. Most people aren't aware of these guidelines, and they're very important, and they completely overlap with our cardiovascular risk. So again, the sex-specific risk factors for women here: pregnancy, preeclampsia, gestational diabetes, oral contraceptive use, postmenopausal hormones, and changes in hormonal status, very similar to what you just heard for heart disease in women. And the risk factors that are more prevalent in women are the migraine with aura, atrial fibrillation, diabetes, hypertension, and then depression and the psychosocial stresses. And where it might not be very different is age and lipids, diet, smoking, and even metabolic syndrome. So the key points from the guidelines, they had the women experience more prevalence of stroke, more death from stroke, more disabilities from stroke. Again, healthcare dollars, very important issue. Hypertension is worse with age and race. African American women have a much higher risk of hypertension and 10 years younger than white women. And AFib is associated with a higher risk of stroke, cardiac events, and mortality in women. And women with diabetes have a higher risk of stroke, just like they do with heart disease. There is lacking evidence with stroke for lipids. So while we think the treatment is important and statins are good for secondary prevention, we don't know that they're part of the stroke etiology. And migraine is more common in women, and migraine with aura is associated with ischemic stroke. So this is also considered a risk factor for stroke. It looks like if you can reduce the incidence of the migraine with aura, you might reduce the risk. And a lot of people still use beta blockers for Rapamil for prevention of migraine headaches. Drugs like Imitrex have actually been associated with coronary vasospasm and myocardial infarction, so that's not always a great choice. And then estrogen-containing oral contraceptives may also increase the risk in women with migraine with aura. So the OBGYNs really should be using different methods. IUDs, barrier are still better in these women for long-term safety and efficacy. So hypertension and stroke are very, very interwoven in women. The Women's Health Initiative showed that older women, and it's not that much older, their mean age was 63, who had prehypertension had a 93% increased risk of stroke compared to normotensive women. And women over 80 have a 90% chance of hypertension. So basically, every woman over 80 who walks into your clinic, she has hypertension, whether she has it that day in your office or not. To pick this up early and treat it is critical if we want to change these numbers in women. And there is huge risk reduction benefit. A meta-analysis showed that women over 55 who had hypertension that was well controlled had a 38% reduction in fatal and non-fatal events. So almost 40% reduction. That's as good as you get with a statin and coronary artery disease. And mental stress is a very important risk factor for stroke. The study in Circulation showed anxiety, depression, and other mental distress was associated with an increased risk of heart attack and stroke in women over 45. So this is a key risk factor to look for. A lot of times you don't want to ask about their personal life or stress, but it's very important to know. It's a slightly stronger risk in women than men, but it's also very important in men. And the risk of heart attack was higher than expected among men 45 to 79 with mental stress. So don't assume, men don't want to talk about it, but don't assume that everything's fine. Ask them about their stress level. This is very important in reducing heart attack in men as well as stroke. So aspirin for prevention of stroke, we still think there's some benefit in patients over 65 if their blood pressure is well controlled and there's no risk of an intracranial bleed or a GI bleed. And it might be reasonable for higher risk younger women than 65. So let's talk about pregnancy for just a second. So thank God there's not a lot of stroke in pregnancy, but when it happens, it's devastating. Pregnancy-related hypertension is the leading cause of both hemorrhagic and ischemic stroke in pregnant and postpartum women. So controlling the blood pressure is essential to caring for these women. The risk is higher in pregnant women than non-pregnant women for stroke. About 1.5 times the risk. And the risk is highest in the third trimester and in that initial postpartum stage. So often, the woman goes home with her baby and everybody's happy and you don't think about follow-up. But these women need to be rechecked within just a few days of going home for their blood pressure if they had elevated blood pressure during the pregnancy. So who's at risk for pregnancy-induced hypertension? Almost everybody. Women who are obese, women who've already had hypertension or a previous gestational hypertension, your first time pregnant, but also your multi-para, so both ends of the spectrum. Any pre-existing vascular disease, family history of preeclampsia or eclampsia, and a lot of women don't know if their parents had anything like this, if their mother had it, so it's important to ask. Again, the collagen vascular disease are definitely an issue. Advanced maternal age, women over 40, women with diabetes, and chronic renal disease. So all of these women need to be watched more closely during their pregnancy. And in Atlanta, we actually have cardiologists in the OBGYN department. We have an integrated women's center where we're right there to see them and talk about them. And I feel like when I'm standing there in front of the OBGYNs every Friday, they're like, oh yeah, this person should see you. I want you to check on this one. What do you think of this one? You get a lot more collaboration with the healthcare for women in the OBGYN department than you do standing in the cardiology department waiting them to come to you. So class recommendations for prevention of stroke in women now include low-dose aspirin, 81 milligram aspirin, for a woman who's had primary or secondary hypertension or a previous pregnancy-related hypertension starting at the 12th week. This is very important. Most of the OBGYNs know it and are implementing it. It's important for us to know it and support that or recommend that if we get asked. And then calcium supplementation seems to be very important in preventing preeclampsia. At least 1 gram a day orally. And these are class 1, should do, strong evidence recommendations. And then severe hypertension in pregnancy obviously needs to be treated. All of our antihypertensive drugs cross the placenta and will be entering the fetus. And so traditionally, we still recommend methyl-dopa, labetalol, and nifedipine. And then postpartum, you got to get these women right back in. Within just a few months of the delivery, you want to see them for follow-up. We recommend starting at 6 to 12 months postpartum that they get reevaluated for blood pressure and risk reduction of any cardiovascular risk factor. So the most important thing I think a woman can do after a baby is get that baby weight off, get back to your pre-pregnancy weight, and then if that wasn't a healthy weight, get back to a healthy weight. We also need to make sure these women aren't smoking, that they're controlling their cholesterol, that they're doing all their traditional risk factors. And a lot of these women are 25 to 35. So, you know, a lot of times no one's even thinking about these things being an issue. Risk of stroke with oral contraceptives, well, similar group, older women, smokers, hypertension, diabetes, obesity. They also have increased risk for deep vein thrombosis, hypercholesterolemia, and any previously underlying thrombotic disorder, any hypercoagulation. These are all very risky. No oral contraceptives. Transdermal might be best, but a non-hormone approach such as an IUD or a barrier method is probably still best. And then hormone replacement. So this is getting a little trickier because some newer studies such as ELITE, SMART, even some of the MESA data is showing that if you start hormones early, and the average age of menopause is 51, and these women need it for a really good reason, like hot flashes, menopausal symptoms that respond well to estrogen, then it might be safe if they take it up to 59. And I want you to know that word might was underlined like 3 times. So I don't want you to leave here and say, oh, Dr. Lundberg is recommending hormones in menopausal women, because that's not what I said. But if you have a woman who's just plagued with menopausal symptoms, there's nothing better than estrogen. And it might be okay in certain women, and they need to be assessed for this. But it's not recommended for primary prevention of cardiovascular disease in women at all. And the serum estrogen receptor modulators are also not recommended for primary prevention. So I'm going to talk a few minutes about AFib, and then we'll wrap up with questions. So basically what this is showing is the women with the highest morbidities over here, group E, they have high blood pressure, diabetes, cigarette smoking, and prior AFib, and this group has prior cardiovascular disease with that list. These women are the most likely to have stroke. Our lower risk women, women with normal blood pressure, lower risk factors, don't have as much stroke. And that's why it's so important in a woman to use the CHADS VAS score to calculate her risk, because the more comorbidities, the higher the risk. AFib is the most common arrhythmia in anyone. It is modifiable with the antiarrhythmics and anticoagulants. And then if you have an EP department that wants to ablate everything, you can get rid of it that way. It does increase the risk of stroke 4 to 5-fold, and it's not necessarily while you're in AFib. It's just having AFib. Having that burden of AFib increases the risk. And it's 1.5% for people 50 to 59, but 25% after age 80. And that tends to be when we decide, she's a little old lady, I don't want to put her on blood thinner, she might fall and break her hip. But what we're learning from studies that track that is they're the highest risk, they're going to have the stroke. Treat them for prevention with an anticoagulant. Non-Hispanic whites have the highest risk, so it's the little old white lady who's having these, much more so than blacks or Asians or Hispanics. And 60% of the AFib patients are over 75-year-old women. Female sex is an independent risk factor, so when you look at CHADS VAS, you get a point just for being a female and you get a point for being over 65. A lot of times with the score is just based on being female, so she's under 65, just treat that with aspirin, count that as a 0. But if the woman has 2 or higher, you need to strongly consider the anticoagulant. And I'm not just saying this because the Pfizer lady's here, but Eliquis is my favorite NOAC. I prefer NOACs over any Coumadin. Coumadin clinics have gone to, only patients basically with valvular disorders or who can't afford the anticoagulant. You put it in your mouth, it works that day, it doesn't have the drug interactions, you don't have to worry about the antibiotics. It's just so much easier and effective. Effective the day it works. You don't keep them in the hospital waiting for that INR to reach 2.0 so you can send them home. So in summary, cardiovascular disease continues to be the leading cause of death for women in the United States. It's an unreached population. There are many subpopulations that need to be evaluated. It's a great opportunity for a women's heart program to address these issues. Women need aggressive cardiovascular risk reduction. We don't want to treat them like frail little old ladies who can't take the medicines. Give them the medicines, please. You need to follow guideline-directed therapy for a woman the same way you would for a man. And women do have these unique risk factors that are related to hormones and changes in life, but also risk factors are more dangerous in women than they are in men. So you want to aggressively treat them to reduce both heart disease and stroke. And I always went in by thanking all of my mentors. I've been fortunate to work with Dr. Nanette Winger and some other leaders in women's heart disease, Annabelle Bogman, Lakshmi Mehta. And we have a great Women's Heart Center team. I don't do all of this by myself. I have a great team that works together. So, question, answer?
That's great. Question?
Does the use of estrogens early in life confer any increased or decreased risk for disease later in life?
So I want to be clear what you're asking. Do you mean like oral contraceptives, or do you mean like the woman who had a hysterectomy at 32 and got put on hormones?
Oral contraceptives.
Yeah. No, while you're taking the oral contraceptives, you know, it's associated with increased risk of deep vein thrombosis and a little bit of increased risk of breast cancer. But once those hormones are stopped, there doesn't seem to be a long-term effect. But to answer the other question you didn't ask, let's say you have a woman who's had a hysterectomy at 32, she's had an oophorectomy. She needs to be on hormones right up until 51, 52, which is the average age of menopause, to protect her bones, to best mimic what would have happened naturally. But then she needs to wean off in her 50s. What we say now is hormones are safe from the time of menopause to 59. At 60, you start weaning them down, and ideally women are off all exogenous hormones by 65.
Are you seeing any signal in the nicotine delivery systems used in younger women now in any kind of events, and cardiovascular events or stroke events? Are you aware of anything in that arena?
So I think we were all very excited when e-cigs came out and vaping, because, you know, at least it was water-based and you weren't going to have all the tars and other things with it, and the AHA wasn't sure what to say initially because we didn't have a lot of data. But as the data has come out, nicotine is nicotine, whether you chew it on your gum or absorb it through your patch on your skin, or you smoke it or you vape it. So it seems that all nicotine is pro-atherosclerotic and is bad. There does seem to be some difference in the lung cancer incidence with e-cigs and vaping. I think it was hopeful early on that that would be a weaning mechanism off, but it actually appears to be a whole new introductory site for particularly young people. It's very, very popular for them to have these little e-cigs and the whole vaping, you know, the hookah bars. I mean, it's very trendy right now. So nicotine is nicotine. It's all bad. I don't think you should say one's better than the other. If you recommend it for a weaning system, there's a good chance your patient's going to get stuck there. I still recommend just, you know, I still use a lot of Zyban, and I use Chantix. Yes, ma'am.
Do you have any protocol for workup for your menopause patients? Oxygen, normal estrogen, everybody kind of different things.
Yeah, so with your Minoca patients, it is very nice if they can have like a PET scan that shows coronary flow reserve. We use a lot of Renexa with these patients. We use nitrates with these patients, and we use a lot of amlodipine, you know, things to prevent any coronary spasm on top of that. We try to get them to still go to things like cardiac rehab because they need to know they can exercise and it's safe. But we watch them very closely. And I also tend to let them sort of self-monitor with taking nitroglycerin. You know, if they take 3 and they pass out, that's no good. But I think that's really important to make everyone aware that this is not a low-risk situation. and to take them seriously when they come to the ER, to take them seriously when they call, and for their primary care physicians not to, act like they don't have coronary disease. They need to be treated just like they have a 70, 80, 90% obstruction because they have the same worst outcome.
Can you, we still get a few patients who say, I heard statins aren't beneficial for women. Can you comment on the origins of that and then the obvious clear evidence that that's not the case?
Well, so in the early studies, women were like 10% of the study, like 4S, 0 women, right? So the problem was, we always had this idea you can't give childbearing women drugs and have them in drug studies. So one thing that's been very important is the FDA came out and said you have to enroll equal men and women because that's the population. And now the FDA has even come out and said we can enroll pregnant women in studies. So it's a huge opportunity to learn from this. But the early studies showed very few women, and then if you have a small N number, you get less quality data. But if you go back to like TNT, a huge amount of women, 40% women. So as the data got better, the information got better. What I find, though, is if it's on the internet, it's real, which is not true. And when patients Google statins, they can get a lot of old data. I've also found, as more of an opinion piece here, patients will go to the internet to support what they already want to do. So if you type in statins bad, you get 50 million things. And if you type in statins good, you get 50 million things. So you can find data on either side. And then, it is like a daily challenge every day with my patients on the statins. Every day. And what I don't get, because I'm going to start preaching now, is if you've got breast cancer, you're going to lose your hair, you're going to lose your weight, you're going to feel like crap, you're going to lay in the bed, and they're like, give me the drug. And a statin, you're probably going to feel fine. 97% of people feel fine, and they don't want the drug. So it's really all in how we present it to them. You need this, it's going to prevent heart disease, this is just as important as if you had breast cancer and you took chemotherapy. Then a light goes off. But if they think it's optional and it's just going to make me feel bad, I don't want to feel bad, they don't want to take it. So the challenge is real.
I have one question. So you, Nancy, outlined that our traditional risk factors may confer different risks for women compared to men, and also that women have different risk factors as well. Do you think there be developed a different risk factor, risk calculator for women? Is that going to be coming out?
Yeah, so a lot of people are looking at this, how to determine risk in women and adding in things like diabetes and giving it higher risk, or obesity and sedentary lifestyle giving it higher risk, and adding in things like rheumatoid arthritis, lupus. They say there's an app for that. There's a lot of new things coming along looking at this. The problem is to make sure it's accurate. So you don't want to overestimate risk and put people on drugs they might not need, but the worst thing you can do is underestimate the risk and tell them you're fine, go away, and then 2 years later that woman comes back and she's had a heart attack. So it's in the works. It takes large populations to develop a good risk. I think the MESA data is helping a ton with stratifying race and ethnicity, and it's also looking at women. So I'm hopeful that we'll have a good risk stratification for coronary artery disease, but we also need one for stroke. Yes?
I was wondering if you could comment on what
So the question is, these women having hypertension, disorders of pregnancy, basically what are you doing to follow up? So the key is to get them in before they deliver, so you can intervene on the hypertension prior to labor and delivery. And then most of these people are safe enough to have labor and delivery by obstetric indication. So most of them are still having normal vaginal deliveries. We try to see them within the first week of delivery because the blood pressure can plummet and they don't need any more meds, and they're vasodilating and they're diuresing, or the blood pressure is even worse, and that's the patient who might be going to a postpartum cardiomyopathy and needs to be watched very, very closely. So we try to get them in right away. And then depending on the woman's underlying risk, if she's a marathon runner and she's a vegetarian, she might not need to see me for 5 years. If she's obese and, stressed out and has 3 other kids at home, I'm probably going to keep seeing her every 6 months for a while. If she gets her risk factors under control, then I'll ease up again. But I always want to start seeing these women again at 40. 40 to 60 is when we prevent heart disease in adults. After 60, everybody has a certain degree of it. So I see them at least once a year between 40 and 60. And particularly if they're going to have another pregnancy, I want to see them before they even think about getting pregnant so we can be on board. Well, thank you all very much. It was an honor to be here.